This is Errol Gottlieb narrating this presentation on behalf of Professor Ida van Biljon. The topic is immature renal function of the newborn. Next slide. A term baby does not yet have mature kidney function, and the more premature the baby, the more immature the function is. Various influences such as intrauterine infections, diseases of the mother, exposure of the mother to drugs, toxins, alcohol, and smoking, as well as various genetic conditions, may further affect kidney function at birth. Needless to say, the earlier the exposure of the fetus to harmful influences, the more the damaging effects are on the newborn kidney function. Next slide. The urogenital system arises during the 4th week of development from urogenital ridges in the intermediate mesoderm on each side of the primitive aorta as early as 4 weeks of gestation. In the embryo, the kidneys develop from 3 overlapping sequential systems, namely the pronephros, the mesonephros, and the metanephros. The pronephros involutes very early. The structural elements of the mesonephros mostly degenerate, but the gonad is developed in their place. Some of the tubules of the mesonephros form part of the final kidney structure. Next slide. The metanephric blastema forms the final kidney structure together with the ureteric buds, which branches out from the caudal part of the mesonephric ducts. Interactive signaling between these two structures involve many humoral factors, and these determine the development of either a normal or abnormal renal tract. Next slide. In summary, the mesonephric bud gives rise to the collecting ducts, pelvis, calyces, ureter, and trigone of the bladder. The metanephric blastema gives rise to the glomeruli, proximal tubules, and loop of Henle. Next slide. On the left is depicted the sequential development process involving the pronephros, mesonephros, and metanephros. On the right is a depiction of where the ureters insert into the bladder, which is initially part of the cloaca. The cloaca then normally divides into an anterior bladder and urethra and a posterior genital tract. Next slide. During the 5th week of gestation, the mesonephric duct develops an outpouching, the ureteric bud, near its attachment to the cloaca. This bud, also called the metanephrogenic diverticulum, grows posteriorly and towards the head of the embryo. The elongated stalk of the ureteric bud, called the metanephric duct, later forms the ureter. As the cranial end of the bud extends into the intermediate mesoderm, it undergoes a series of branchings to form the collecting duct system of the kidney. It also forms the major and minor calyces and the renal pelvis. The portion of undifferentiated intermediate mesoderm in contact with the tips of the branching ureteric bud is known as the metanephrogenic blastema. Signals released from the ureteric bud induce the differentiation of the metanephrogenic blastema into the renal tubules. As the renal tubules grow, they come into contact and join with connecting tubules of the collecting duct system, forming a continuous passage for flow from the renal tubule to the collecting duct. Simultaneously, precursors of vascular endothelial cells begin to take their position at the tips of the renal tubules. These cells differentiate into the cells of the definitive glomeruli. Next slide. Amniotic fluid is composed mostly of urine, which is secreted by the fetus from the 9th to 12th week of gestation. Amniotic fluid is recirculated through the fetal gut after being swallowed and is then excreted into the amniotic cavity by the fetal kidneys. Oligohydramnios is an important clue to abnormal renal development or urinary obstruction. Next slide. Amniotic fluid volume roughly equates to fetal renal function. A normal fetal urine rate often exceeds 5 milliliters per kilogram per hour. A 1 kilogram fetus will therefore pass approximately 5 mils per hour or 120 mils per day of urine into the amniotic cavity, but this volume starts reducing close to term. Next slide. Kidney development or nephrogenesis is completed by 35 to 36 weeks gestation. One of the risks of premature delivery is that nephrogenesis is disrupted. The placenta is the major regulatory organ of the fetus, and therefore fetal kidneys do not contribute to normal homeostasis. Next slide. A premature baby at 28 weeks has a GFR of 12. A newborn term baby only has a GFR of 40. This increases to 80 by 2 weeks of gestation and only reaches full adult levels, which is above 90, by 2 years of age. Next slide. One would definitely expect a baby to pass urine within 24 hours of birth. If you test a baby's serum creatinine under 24 hours of birth, you get a value that is high and reflects the mother's serum creatinine level. To determine a baby's true serum creatinine level, it is important to wait a number of days, and then one expects the serum creatinine levels to be less than 35 micromoles per liter. Next slide. This table summarizes the important understanding of the variable GFR levels at different ages from prematurity to 2 years of age. This understanding is critical to clinical prescriptions of fluids, electrolytes, and drugs. Next slide. Although newborn babies have reduced renal function, it is appropriate to their needs. They are, however, then susceptible to renal insufficiency if adverse conditions occur such as birth asphyxia, respiratory distress syndrome, sepsis, significant fluid shifts, overconcentrated baby feeds, and exposure to nephrotoxins, especially herbal medication or aminoglycosides. Next slide. Blood pressure also gradually increases with age. Mean arterial pressure often is approximately the same as gestational age in these age bands, as well as in premature babies. Next slide. Newborn babies are born with excess fluid in the extracellular compartment, hence babies often look puffy with swollen eyes at birth. Post-delivery, that volume overload reduces, and subsequently babies can normally lose up to 10% of their birth weight in the first 10 days of life. Babies cannot tolerate high fluid administration, especially if given intravenously, and this can predispose babies to dilutional hyponatremia. Next slide. Newborns can dilate urine normally but have reduced renal ability to excrete large water loads and also have a reduced renal ability to concentrate urine. Next slide. Of particular importance in newborn renal function is the reduced renal capacity to concentrate urine. This is as a result of reduced renal responsiveness to ADH, an inability to maintain the corticomedullary osmotic gradient, and poorly developed tubules in the medulla. Next slide. As babies age, their kidneys progressively improve their ability to concentrate urine, as depicted in the graph. Next slide. Apart from not being able to adequately concentrate urine, babies also lose an excessive amount of sodium in the urine. In premature babies, this is due to functional immaturity of the proximal tubules. Sodium chloride is also lost due to reduced sodium chloride reabsorption along the ascending loop of Henle and decreased reabsorption of sodium in the cortical collecting duct due to reduced sensitivity to aldosterone. Next slide. When newborns are exposed to concentrated feeds or intravenous fluids with a high sodium load, their kidneys are unable to excrete this high sodium load. Premature babies, though, tend to lose sodium and can go into a negative sodium loss. Next slide. The listed conditions in this slide can all predispose to fluid and sodium overload in preterm babies. Next slide. Term and preterm babies differ in potassium homeostasis. In term babies, it is more common to find a low serum potassium. However, in preterm babies, they often have a raised serum potassium. Factors that will aggravate hyperkalemia are hypoxia, metabolic acidosis, catabolic stress, and hemolysis. There is also reduced responsiveness of the distal renal tubules to the effect of aldosterone. As a reminder, aldosterone is a mineralocorticoid that acts primarily in renal collecting ducts to stimulate reabsorption of sodium as well as secretion of potassium and hydrogen ions. Next slide. Premature babies struggle to maintain a normal acid-base balance. The causes of this are net acid excretion by distal nephrons and reduced reabsorption of sodium bicarbonate in the proximal renal tubules. On occasion, premature babies, especially a very low birth weight, may require oral administration of sodium bicarbonate to maintain a serum bicarbonate above 20 millimoles per litre in order to encourage feeding and weight gain. Next slide. A number of physiological consequences arise due to immaturity of the tubules. They include an increased fractional excretion of sodium, loss of glucose in the urine despite normal blood sugar levels, reduced bicarbonate reabsorption, reduced acidification of urine, reduced ability to concentrate urine, and increased calcium loss in the urine. You can appreciate that all the above can have quite a significant impact on a premature baby, and understanding these consequences helps significantly in clinical management decisions. Next slide. Not uncommonly, moms with newborn babies do not breastfeed adequately, with the potential to cause hypertonic dehydration. Aggravating factors are increased loss of water through premature babies' thin skin and reduced concentrating ability of the tubules, aggravated by the possible presence as well of glycosuria, which causes an osmotic diuresis. Of importance is that one needs to slowly rehydrate with an appropriate intravenous solution, which may need to contain bicarbonate if the premature baby has a metabolic acidosis. Next slide. It is now possible to treat and save a 500-gram premature baby, and in rare situations, even premature babies weighing less than that. It is important to use appropriate premature feeds and intravenous solutions which avoid high protein load and high sugar concentrations. Next slide. Many studies have shown that being born premature with small kidneys may well predispose those babies to chronic kidney disease, hypertension, metabolic syndrome, and cardiovascular disease in adulthood. Next slide. This slide marks the end of the presentation. Many thanks for your attention.